Hello.
Hi, Eric. How you doing?
Good. How are you? Thank you for having me.
Good. No, thank you
Fun.
for presenting. What time is it over there?
8 o'clock.
Okay. Well, thank you for making time for us. So
Oh,
we
I've
usually
got a
I
lot
give.
of time now. I mean, I had time to sit down for dinner, um, kids to bed. I've got hours now.
We'll give everyone till around like 1:05 when everyone showed
Yeah,
up, and
sure.
then
No problem.
but,
Yeah, I
yeah.
mean, I basically put together just a string of cases, and I
Yep. That's
had
fine.
um, more than enough material to fill the hour. Um, so we'll probably have to cut some of the cases out. We run out of time.
Yeah, that's fine. Oh yeah, great. You can save those for the next time. So
Yeah.
yeah. And then what's your background? Because I always interested to find out.
Well, I'm Pam. I'm not POCUS trained. I just kind of
Okay.
I I started at Kaplan Hospital in 2016, and they had an ultrasound machine. So I picked up the probe um, and started playing around with it and did some independent learning. And then the folks at DC were kind enough to allow me to join with them over a summer in 2018.
Oh, okay.
And so I got a taste of training.
Great. That's awesome.
Just been doing it ever since.
Great. Yeah, well, I look forward to seeing your cases. Yeah, that's awesome.
Well, let me know when I should start.
Yep. So we'll give around like around 1:05, so a couple
Okay.
like 5 more minutes, and then we'll get it going.
We're at 8:05, 8:05 local time. I guess it's 1:05 Eastern time. Can everyone hear me?
Yeah, we can hear you. Let me just, yeah,
Yeah,
yep. All
I'll
right, you
bring
beat me to
a
it.
minute by telling everybody that April 1st, 1972 was the day in which Richard Nixon made it illegal to advertise cigarettes on radio and television, which was a big in U.S. public health history. There, burned another minute.
Yeah, that was pretty good.
Also the day that Apple Computer was founded. Don't know what year.
Really? All right, it is 1:05. So good afternoon, everyone. Thank you for joining again. This week we have Eric joining us all the way from Israel. Thank you, Eric, for being up and presenting to us, and I look forward to, and you can take it away at any time.
Well, thank you for having me. It's a pleasure to be here virtually, at least. My name is Eric, and I am not POCUS trained. I'm trained, and I've been doing POCUS for the last 5 years. Some say I have a knack for it, but basically what I'd like to do is to present a series of cases. The majority have some relevance to the abdomen, but as I was putting the case series together, I realized a lot of my cases were redundant. So I have some abdomen cases and then some other cases I thought were interesting. And what I'd like to do is just to put the images out there, talk a little bit about how they presented and what the images and show the images, and then open it for discussion rather than it being a literature review. And so I am thrilled to be here, and it is April 1st. So if you thought you were getting a presentation from POCUS Effort, well, April Fools. So this is where I work. This is Kaplan Hospital. We are in Rehovot, Israel, which is inland. So contrary to popular belief, we don't all live on the beach. About 45 minutes to the beach. We have an emergency room on the second floor, and then the third and fourth floors are inpatient units. It's a nice little hospital that is not freestanding. It's connected to a larger general hospital, and that's where we send patients to radiology if need be, which is a long walk, so I like to do POCUS as much as possible. We see, I'm hiding my own screen here. We see the middle of Israel. About 10% of the Israeli population. Israel has about 9 million people, and we have a very diverse population coming in. And my first case is an 11-year-old who came in with 1 day of pain, and I am going to be checking chats. I like your clean slide. Thank you. Thank you very much. So this is an 11-year-old, 1 day of pain, started periumbilical, now right lower quadrant, no fever, vomiting, but he comes in with a VAS of 8. Right lower quadrant exam, he's tender with guarding and rebound. He's got a normal CBC except for a bit of a shift, and his CRP is a little bit elevated at 2.5. So pretty much a slam dunk for appendicitis, right? At least that's what I thought when I walked in the room. And not moving. There it moves. Okay, so I put on a curvilinear probe over the right lower quadrant. This is a little bit of haze, and this is actually an old. This is actually an old slide of mine. This is an old case that came in. I actually don't remember, over a year and a half ago, probably. This is a little bit of haze of psoas. I've got some color flow indicating the iliacs, and right over here, I've got this structure that I thought was slam dunk. Oh, this is appendicitis. I've got a tubular structure. It's got some surrounding hypoechogenic areas, which could be fluid. And on my still here, I've got again, this is a tubular structure with a layered. I'm thinking, okay, here's the appendiceal lumen here. Here's my blind end. It's got to be. And then I looked at it again and I thought to myself, wait a second, maybe not. So I called the surgeon in to assess the patient. You can see here also, I'm putting a little bit of pressure. You can see here are my subcutaneous layers, and you can see I'm putting a little bit of pressure here. He was in a lot of pain, and you have some hot fat in this area. And here I am going through a video, and I've got this tubular structure, but the appendiceal layers look kind of odd here. So I called the surgeon in to assess, and he examined the patient and agreed with me that this was an acute abdomen. And the child needed quite a bit of narcotic to be comfortable. And so, was it appendicitis? Well, he went for laparoscopy just based on the clinical assessment, and it turned out to be omental torsion. So what we're seeing here, and we'll play it again. What we're seeing here are layers of omentum that have that have torsed on some sort of a pedicle here, which we don't see, and surrounding fluid that makes it more visible. And this is one of the mimics of acute appendicitis. It is rarely seen in children. I actually couldn't find anything in the POCUS literature, at least. You find it in surgical textbooks that this is one of the mimics of appendicitis, and that it generally, it can get better on its own. But resection can decrease the risk of developing adhesions, so the surgeon here decided that he was going to open and found omental torsion and resected. So lesson learned is not everything that looks tubular is appendicitis. I am going to check my chats. Okay.
And Eric, do you know if there's any way the differentiating that from like appendicitis? Is there any tricks from what you saw in your literature?
So, yeah, so I did not include a picture of appendicitis, but basically this is an odd looking appendix. I don't, the appendix has 5 layers. I don't see my layers that well, and I've got some sort of my blind end here has an abnormal shape. So this child didn't go for formal sonography. He was just taken to the OR based on clinical assessment. But this is a weird looking appendix. So my takeaway from this is, if it looks like a weird looking appendix, it might not be the appendix. I learned that in my first couple of years on all of these, on the ileum that I called 100 times appendix. That was, luckily I sent all those children into formal radiography in my first few years. I've since learned what an appendix looks like, and this is not an appendix. This is a strange looking appendix. So if it's a strange looking appendix, get a second opinion. That's my takeaway for that case. Case number 2 is a 9-year-old with a history of single kidney, day 4 of severe colicky suprapubic pain and multiple episodes of emesis. His brother's got FMF, which is familial Mediterranean fever. And this is something that every Israeli physician needs to know. I mean, if they wake you from sleep and ask you a question about FMF, you need to know, because we are Mediterranean, so we do see this a lot. On exam, he doesn't look well. He's got diffuse abdominal tenderness. His CBC is normal, and the CRP, again, is just slightly elevated. So again, here we have a child with a family history of FMF, and he's got day 4 of severe colicky suprapubic pain with multiple episodes of emesis. I'm really not thinking about appendicitis, but this case just came in about 2 weeks ago, and this kid, the surgeon happened to be walking through the ER to see someone else, and so I called him in, and we did the scan together. Which is one of the beauties of POCUS, one of the things that's developed in the last couple of years since I've developed a knack for it, is that there's a better working relationship with the surgeons. I speak to them about my POCUS exams. I send them on WhatsApp some images, and sometimes we'll even do the exam together, because when you do the exam, when you're actually there, you get a better sense for the pathology. You can see where the child is tender. You can better correlate the physical examination with your ultrasound findings. So the first thing I noticed when I put a linear probe in transverse orientation over his right lower quadrant was this dilated bowel loop. I went right for the appendix. I found a normal appendix, and then we started looking at this bowel loop. And what we found was that he's got a large loop of, this is cecum over here, and there's really no peristalsis. In fact, it's going in two directions. Did I put a better clip in? No, I did not. So this child had a dilated loop of bowel with absent forward peristalsis. The test of choice for bowel obstruction is still CT, but POCUS is a close second. There was POCUS is number one, is much better than X-ray. X-ray, the specificity is about 67%, according to one series, and for CT, POCUS comes close. I think there was a meta-analysis in 2018. The sensitivity of POCUS for small bowel obstruction in an adult population was 92%, and the specificity was near 97%. This was a child who then went for X-ray. At this point, the surgeons are managing him. And you can see here air fluid levels. There's not a whole lot going on here. This is an upright film, and this is his supine film. A little bit of air distally. And this is his CT. And you can see here air fluid, big dilated loops of bowel. This is, if we had seen this on the ultrasound, this might be a keyboard sign. It's a little bit of what's the word in English? House trip. And air fluid levels. So this child, so what happened? So he had other CT images showed that he had a proximal bowel obstruction that was caused by adhesions, one of which caused this partial obstruction that he had. He had serositis along the small bowel wall. Why did he have serositis? Why did he have adhesions? Because he likely has FMF. And our surgeon, because we have FMF so commonly in Israel, our surgeon had seen a similar case of adhesions that had formed as a result of multiple episodes of inflammation and serositis that causes this kind of scarring of the gut. During the hospitalization, he developed fever and some chest pain. His evaluation of that fever didn't show any other source, and so he started on colchicine as per our rheumatologist. And he does likely have FMF. And the following week, when it rains, it pours. The next week, I had an ER, a 17-year-old who had FMF and was being evaluated for IBD as well. And he came in after MRE with, again, colicky, abdominal pain, and vomiting. Had exactly the same pictures that I showed earlier of dilated bowel with no forward peristalsis. And then it all just resolved. So in a lot of cases, and the cases I'm bringing here are, some of them are not complete obstruction. So this one, some of them do resolve without surgical intervention. This is a 5.5-year-old with chronic constipation since age 3, treated routinely with glycerin and Normalax. Normalax, I guess, is Peglax in the US, with some typos on my part, sorry about that. So he comes in with fever of 39.3. He vomited once, and his abdomen is distended, hyperdynamic, and tympanic. I took all of this from the residence exam because I saw him on morning rounds. So I, as a PEDS doc, on weekends will round on inpatients. And one of the beauties of that arrangement is that I get to catch things that got missed. So they had examined him And then I put the probe on morning rounds, and I can see this is a transverse view of the mid right lower quadrant. This is bladder. We have a little bit of free fluid here. A little bit of free fluid. Here's kidney, liver. Here's the left lobe of liver. You've got a little bit of free fluid by the left lobe of liver. So I already know that there's some pathology here. And then I notice as I come down the edge of the liver, I notice that he's got this large loop of bowel with this hyperechoic rim. I measured it, and I don't remember the measurement, but it was large. It was 3-4 centimeters. And then I put the probe on, and we're looking here at. So here this is a coronal view from the left flank. So there's a lot of bowel gas here that obscured a lot of what was going on here. And sometimes with these, I've had a few of these so far, and sometimes you kind of have to hunt around for this area that is where the money is. So you can see here, he's got dilated loops of bowel, and there's this washing machine effect. It's going nowhere. And I apologize, it's my chat break. So this is his x-ray. You can see big dilated loops of bowel, not a whole lot going on distally. So what happened? So he went back for a second KUB after his NG tube was placed. And the repeat KUB did show some air to the rectum. They decided that he was not completely obstructed, so let's wait. So they repeat lab showed a decrease in his CRP. I'm actually not sure what caused his increased CRP and fever, and it may have just been bacterial translocation from all of this this pseudo obstruction, we'll call it, because they brought him in for irrigation via rectal tube and just cleaned him out. And his abdominal exam normalized. It took a few days of clean out in order to get him clean, but he went in following this admission for GI fluoroscopy. It showed dolichosigma, which I had to look up, and it means that his sigmoid is elongated, and that may have that is one of the contributing factors to chronic constipation. This is a sagittal view using a curvilinear probe over the mid pelvis, and here's my sagittal view of the bladder, and I think that this might be our dolichosigma. We just have a long loop of large bowel here that tapers into the rectum with just a lot of fecal material. He's being evaluated. This is also a recent case, and I called the mother a couple weeks back to find out if they had actually gone for any of this, and she said, "Oh yeah, I'm getting to it," but the child needs an evaluation for cystic fibrosis, for thyroid disease, and for celiac. And now that he's back on Normalax, he is well again. At least that's what the mother says. We will see. So this is another interesting abdominal case, and this was one that came in. This is the end of February, so yeah, about a month ago. 17-month-old female. So this kid came in with 1 week of intermittent episodes of crying. Mom said that she was bringing her legs to her abdomen, and she was pointing to, she's pee-pee. She had no fever. She had a single episode of emesis 5 days before presentation. And during this week, she saw her pediatrician a couple of times. She started on amoxicillin for the pediatrician saw leftotitis, and started her on amoxicillin. The pediatrician also, they discussed teething. They dipped her urine, and I can't really fault the pediatrician, because when I saw her, she presented her chief complaint, or the triage complaint that we see on the board, was fussiness. And I'm looking at this child who is well appearing and comfortable and sitting in her carriage. And I brought her in and started examining her. She had some mild lower abdominal tenderness. And as I'm wheeling our Zonari machine into the room to do her ultrasound, because I ultrasound everything that presents as abdominal pain or tenderness, I'm talking to the mother about maybe it's pinworms, who knows? We have pinworms out here also. They are endemic in younger kids. And so I put the, and I don't want to, they're endemic, but with pinworms, I don't remember having seen them in the United States, but they're more of a nuisance, and we do get a fair bit of volume in outpatient pediatric clinics for treatment of pinworms, and they tend to be in more densely populated, lower income areas. So that's my 5 cents on pinworms. But I'm looking here. This is a curvilinear probe over the. I'm on the left lower abdomen now, and I see this mass, and it's 4 centimeters diameter. You've got a little bit of mixed echogenicity in here, and these areas here that almost look like follicles, and a little bit of fluid around the rim. And I thought to myself that, number one in the differential is ovarian torsion. And I took the mother immediately to the gynecology suite to have them repeat the ultrasound, which confirmed torsion. And the sad part about this case is that I saw a cyst on the right. She had a small, simple cyst. It was a centimeter or two. And I couldn't find the right ovary, but she's 17 months. I'm not the expert in finding the right ovary in a 17-month-old. And the gynecology department, when they did their ultrasound, they saw a rudimentary right ovary, and they took her for detorsion. She had advanced ischemic changes, and then she came in a month later, which was just a couple of weeks ago. Again, with several hours of fussiness, refusal to eat, and she had pharyngitis on exam, so I'm not sure what was what, but the gynecology ultrasound, this actually was not a visit in which I participated. Gynecology ultrasound, again, was concerning for torsion, and they took her for XLAP and saw, again, left ovary and anexa had remained necrotic, so they had to resect. So that is a story that drives home the importance of focus in all settings, not just in the ER. And I think one day, I saw recently there's a new handheld machine out. There's the GE put one out that is reasonably priced. I think that priced it at $5,000. And I remember some of, when I was coming out of medical school, people were talking about these electronic stethoscopes, and they were paying, $800 for an something like that for an electronic stethoscope. Ultrasounds are going to be in that range, and I think that this is going to make its way into settings outside of the emergency room and hopefully prevent outcomes like this. Are there any questions at this point? I'm checking chat again, and I will go on. So I hope that this is all useful. I'm just kind of throwing cases out there to bring awareness that these issues exist, and maybe show some images that you haven't seen before. But if there are any comments, especially, please educate me. If there are any comments or images that things that should have been seen that weren't, please let me know. Case 5 was another case that presented. I saw him on rounds. And this was a 13-year-old, day 1 of nausea and abdominal pain, afebrile, he's vomiting. I think his labs are all pretty normally to normal serum amylase, which in and of itself doesn't rule out pancreatitis, but it is such an acute setting makes it highly unlikely. They did an abdominal X-ray because, I don't know, and that was normal. And the PED fellow who had seen the child the day before did a POCUS, and it was normal. And in most POCUS, what's the word I'm looking for? Algorithms, most protocols. This was a normal POCUS because we did not look at the epigastrium. And so this is a series of photos. This is the first day I saw him, and it was a weekend. So this is the second day I saw him. It was a long weekend, I think. So I saw him on the third day. And these are the photos. This is a transverse view of the epigastrium with a linear probe. And you can see how thick the stomach wall is. Here's your lumen. I started him on a PPI and fluids and a very light diet. And day 2, you can see he got better. He's the swelling is going down. Day 3, the swelling is markedly improved, and he feels much better. And I did a little bit of reading on this, and I just there's not a whole lot in literature on gastritis, on POCUS. And how this could be useful, because bottom line is these are fun images, but how does this change management? And I still don't know. There is some talk in literature on persistent gastritis being a high risk for H. pylori, which is also something that we see quite a bit out here. But he improved so quickly that I think H. pylori was unlikely and wasn't something that we tested for. He got better so quickly that I didn't send for a GI consult. He followed up as an outpatient and was better, and so they didn't scope him. Nowadays we don't do any other testing for H. pylori. In the old days, we would do breath tests or fecal antigens, and out here, at least, we send all of these children to gastro, and those who are persistent or who we have a whiff of H. pylori, we do what we call it here gastroscopy, and you guys call it an EGD. See, also here's his pylorus. That's kind of a cool picture. All right, case 6 is fever and abdominal pain. And again, I'm just kind of throwing all the cases out that I thought were interesting that I saw, except the first case was an old case, but the others, these are all kids I've seen in the last month or two. Fever and abdominal pain. This is a 4-year-old female, 3 days of fever and abdominal pain, and she vomited. And she's got this sky-high CRP. This is 32 milligrams per deciliter. Her CBC was normal, and she's got a dirty urine. So what does she have? She's got a UTI. Why does she have a UTI? So she's got belly pain. She had lower abdominal pain. So I put a probe on, and she had no signs of appendicitis. Her ovaries look normal, and she has this bowel. Here's your bowel wall, and you've got this like our child in case 3 who had this the worst obstipation I've seen in a long time. This child has this. You've got this hyperechoic rim, kind of dirty gas under it, some shadowing. And your diameter is big. Again, I didn't measure this, and a lot of times I just don't measure. I'm kind of with Dr. Adam Sivitz on this. I've heard him say a couple of times that he is not in favor of measuring everything, and I'm not either. Just you look at it, and it's very wide. Here is this looks transverse. This is actually, this is transverse. I'm sorry. This is a curvilinear probe now, transverse under the bladder, and this is her rectal diameter. Stephanie Doniger wrote on this some years ago that diameter over 3 centimeters is indicative of chronic constipation, and this was way over. I think this is 5. And what was interesting to me was I do fast exams. So I do fast windows. This is not a fast exam, it's a fast window in medical abdominal pain. And this is her left kidney. And you can see it's got probably grade 2 hydronephrosis. And we cleaned her out. Here is this is a child who also, a lot of these kids I see not in the ER, but on the floor. I saw her in the ER, and that was on a Thursday. And then Friday, I saw her in rounds the following morning after she gotten a little bit of clean out, and her hydronephrosis is better. This is again the left. And it's just kind of an interesting, this is an interesting view on how POCUS might not necessarily change management in this case, but it gives you a good idea of what the pathology looks like. This was severe constipation that was causing her hydronephrosis, which is, constipation being a risk factor for UTIs. But that's how it happened. It put pressure on the ureter, is my assumption, and caused her to have some retention of hydronephrosis, and that probably caused her, her pyelo, and again, like our case of chronic constipation that presented with high fever and a sky-high CRP. Here too, we have a high fever and a sky-high CRP. That may be from the bacteremia from this back pressure and hydronephrosis. She got very, very quickly on IV antibiotics. And then, this was actually a case that was right before Passover. They decided they wanted to be home for Passover. So they checked themselves out, and I haven't had a chance to follow up with her. I assume that she got better. So those were my abdominal cases, and we're now at about 20 minutes left. I'd like to present a few cases that I thought were also of interest that highlight this. The next two cases are lower extremity fractures, and I just want to show you how ultrasound can be more sensitive for these fractures than X-ray. So this is a 2-year-old female with day 4 of limp. She's got no fever and no history of injury, and difficult to localize pain on exam. And this, so what I did was I just scanned the leg. I scanned both legs actually, and the rest of the leg was normal. When I get to the hip, what's the pathology on? This is the pathology was on. I did not say. I also didn't report it in my images, but on one side we have a normal hip. You've got here your epiphysis, your physis, your neck, and your shaft. And were you to have an effusion, you would see it in this area here, where the ellipsoas, underneath where the ellipsoas inserts. I usually measure from the portion of the femur that has become flat to the synovium. And here on this side, you've got the same structures, epiphysis, physis, surgical neck, but you've got this buccal fracture here. And that was the source of her pain. This is her x-ray. And I honestly, I couldn't find it. The orthopedist told me that it was over here. I wish I could blow this up for you guys, but over here. That is a little bit lower. The buccal I saw is on the neck, so it's here. But I don't see it on either side. She, in the end, so she had a fracture with no source, and so she got a visit from our social workers and our child protection crew. And bottom line was nothing was found, and she went home well. That was kind of an interesting find an ultrasound that I couldn't find in the x-ray. This is a similar case, a 3-year-old who on the day prior to admission, jumped on a trampoline and landed on his knee and was non-weight bearing since. They saw him in urgent care. They x-rayed the hip for some reason, and it was normal, and sent him. He comes in. He comes in the following day to us, and he's hurt, but it's hard to tell where, and it's even hard to. I mean, you can see on which leg he's non-weight bearing, but every time we try to approach him, he withdraws into mother. Every time I'm palpating, he cries. So it's hard to tell where he hurts. So I scan the entire leg. This is the well side. You can see this is his proximal tibia, and again, linear probe, using a lot of gel, very gentle sweep over the leg. I will go from hip down the shaft, and I'll usually do 2 orientations. I go down sagittal, just following the cortex, and then turn it transverse. And again, just look at the cortex for breaks. And this is the affected side. You can see, again, proximal tibia. Here's a buccal fracture. Now, here's this film. Where's our buccal fracture? So if you put a magnifying glass on this, there is a little buccal fracture here, but I thought this was another interesting case showing how useful ultrasound is in these cases. And case 9 is torticollis. I'm going to stop for a moment and see if we have, are there any questions or comments? Hope this is useful for people out there who are using probes in innovative ways. So this kid came in, I think 2 weeks ago. It was actually kind of a cool case. 9-year-old, and he's got this remote history. He had a thyroglossal duct cyst that was noted on his prenatal ultrasound. He's now on day 3 of amoxicillin for throat pain, presents with torticollis. Afebrile, no trauma. On exam, the resident presents the exam. He's got an enlarged submandibular node on the left, and otherwise, pretty normal exam. And there, and this is the kid. Okay, so he's got the classic cock robin position. I mean, can I discharge him now? So his examination was notable for tenderness. So he did actually have torticollis. You could feel his sternocleidomastoid muscle was taut over here, and he's also tender over there. And he's got this history of thyroglossal duct cyst. I think when he was about 1.5 years, he did have an infection. When we opened up his chart, we looked back, he did have an infection, and we decided to put a probe on his neck. And so here's physical exam. Physical exam, this is a well-appearing child, is afebrile. I believe, yeah, he had a normal CBC and normal vitals as well. I mean, this is the most benign presentation of pathology I've seen in a while. This is his throat. You can see he does not have pharyngitis. And this is his ultrasound. Here, I'm transverse over the left anterior neck. You can kind of see here the hyperechoic rings of tracheal cartilage. You can see over here the great vessels in the neck. And here, surrounded by increased blood flow, here is this pocket of mixed hyperechogenicity. You've got big hypoechogenic areas. This is an abscess. And it was big abscess too. It was 4 centimeters. Fanning through, you can see esophagus is down here, tracheal rings over here, and again, vessels are here, and the abscess is sitting. Here's his thyroid. The abscess is sitting within a wing of the thyroid. So, right after I do the ultrasound, I'm on the phone with the ENT, describing the ultrasound, and they saw him very quickly and decided that they were just going to start IV antibiotics. We actually wound up putting him in the ICU for observation. Although the NTs, surprisingly, were very, I don't want to say unconcerned, but ordinarily when you have a deep neck abscess, I worry about potential airway issues, about mediastinitis, about severe complications. And then they were like, well, we've seen this before, we'll start them on antibiotics and we'll aspirate tomorrow. And that's actually what happened. This is a view of the needle as it's in the abscess pocket. You can see how they're draining a lot of this hypoechoic material is now gone. And on the day I discharged him, I repeated, and he's still got this large area of abscess, but much less hypoechoic material. And they saw this as well, and they said, he's clinically well, continue antibiotics, and we will follow this. And this is just a couple of weeks ago, so I don't know what the long-term plan is with this area, if he will have surgery sooner rather than later so that this doesn't happen again. Also have an interesting use of ultrasound. And this is my last image. And this is just kind of a fun image to end with. The quality on the machine was so much better. But basically, this is a baby who came in one night, a couple of weeks old, and no, I'm sorry, maybe a couple months old, 2 or 3 months. This is a 2 or 3 month old who came in. The parents had noted some swelling over the left inguinal area, and previous images had showed that the testes had flowed. There was fluid in there was a hydrocele there, and then he starts to cry, and you can see how his hernia, his inguinal hernia, is. You can see the bowel as it's herniating into the sac, which I thought was a really, really fun image. And with that, I will end in summary. Not everything tubular non-compressible is an appendix. Pay attention to bowel diameter, wall thickness, and peristalsis. It's actually one of the first things I do when I put a probe on an abdomen, is just to take a look at what the bowel is doing. Our residents still will take the time to put a stethoscope on the abdomen and listen. And I listen with my ultrasound probe. You can tell a lot from peristalsis. A lot of times I'll put the probe on a child with abdominal pain and see that absolutely nothing is going on in the gut. There's no peristalsis, and I know that I'm not picking that probe up until I found what's wrong, because that kid is sick. Pathology is dynamic, so repeat abnormal exams. Case 3 with the severe constipation and bowel obstruction. I did his POCUS a couple of times afterwards. I did include the images because they were normal. And so repeat abnormal exams, you never know, they may normalize. And you may get more information that helps to guide the subsequent evaluation. If you don't know what you're looking at, ask a friend. And I'm glad to have good friends now in the POCUS community who I am presenting to right now. And I appreciate any feedback and comments. We have another 10 minutes, and if there are any thoughts or questions or comments, please write or ask.
Eric, that was a great presentation. There's a good pathology to see in there. It's definitely, what you say, the fact that you're able to repeat them once they're inpatient definitely kind of shows why POCUS is also going into the hospital section here in the United States. Great, interesting cases, as a lot of people are remarking in the chat.
Thank you. If I have a minute, I can actually present one more case where I had no idea what was going on. Is that of interest to the Hive?
Yeah.
I'll be interested. All right, maybe, okay, so I'm going to go to, this was actually a case I took out because it was just too long, but it's a really cool case. Let me know what you guys think. This is a 17-year-old. Can you all see? Am I sharing my screen?
Yes.
Okay, with 1 day of, I have to hide this. 1 day of right lower quadrant pain referred by the PMD for rule out epi. And the kid comes in and he is well appearing. His pulse rate is in the 70s. And he's got some mild right lower quadrant pain. And within the first 5 minutes of the visit, with history, physical exam, and focus, is I sometimes would just, when I see a kid coming in and the chief complaint is right lower quadrant pain, I'll have the ultrasound machine in the exam room. We'll just do the whole thing in one shot. I had a kid come in actually last night, same presentation. I had him in and out in 15 minutes. He didn't have appendicitis. End of story. And a lot of other causes of right lower quadrant pain in a boy. If you've ruled out, testicular torsion as well, then there are very, very few emergent causes of right lower quadrant pain. So I feel comfortable discharging these kids quickly. This kid came in, and I was, same sort of presentation. I'm ready to discharge. And after POCUS, I'll present the POCUS images in just a minute, but we started talking about cardiac issues. He had 3 months of intermittent left-sided chest pain, lasts for seconds, nothing that sounded pathologic to me, not related to exertion, nor shortness of breath. There was some family history. The father had an ASD repaired at age 30. And the kid, I'll just throw this out there, normal EKG, normal chest x-ray is part of the subsequent evaluation, because I did a right lower quadrant exam, and then I used fast windows, and I'm just kind of coming over his, this is the right upper quadrant window, and his IVC catches my eye. And I'm looking at IVC. I've got my hepatic ring running into it. I got liver on both sides. So I'm fairly certain this is IVC, and it's just plethoric. And you can see also here, I turn to transverse. Here's my aorta, and here's my big IVC. So I was wondering why he has a plethoric IVC. Here's his change with inspiration. Again, you can see, it's not doing very much. I've got here a big dilated hepatic vein running into my big dilated IVC, which is clearly between two lobes, it's got liver on both sides. This is IVC, and it's big. So here's his long view. It looks just fine. His short view, you've got your fish mouth here. Also looks pretty good. Yeah, kind of a combination of fish mouth and papillary muscles. This is a fourth chamber. I'm trying to look at his tricuspid. I'm thinking maybe I can see signs of. You've got here. I can tell you've got no sign of increased right ventricular pressure, because your left ventricle is circular. So there's no sign that there's right ventricular pressure that's pushing your septum leftward. Here too, you can see that. And the tricuspid valve looks okay. Bottom line was, this was a pretty normal cardiac exam. Then I did the EKG. Then I sent him for a chest X-ray also. I just couldn't figure out why he had. Why he had this large IVC. I, in the end, did a complete. We did labs. I sent him for formal ultrasound. On the pretense was rule out appendicitis, but I asked them. I told them I got this big IVC. Look around. What is causing this? And they sent me back an answer. Normal abdominal ultrasound. So I still have no idea. I discharged him. There was no sign of a PE or anything that was dangerous, and he went for formal echo about a week later. I spoke to mom, I think a week or two ago, and he had a normal echo. So I have no idea why he has a plethoric IVC. And it extends beyond the liver. So, I thought initially maybe the obstruction is at the level of the liver, kind of a Budd-Chiari situation. This extends beyond the liver. You've got hepatic vein dilatation. So maybe the echo wasn't really, I can't make heads or tails of this. So if anybody has any ideas, please let me know.
You say he was there with right lower quadrant pain?
He had a day of the right lower quadrant pain. And that was it.
Did he had abdominal distension at all?
Nope. The rest of the abdominal stem was totally normal. No varices anywhere.
Yeah, it's interesting. Yeah, I don't, based on everything you did, I don't really have a good explanation for that. I don't know if anyone else would have a different thought.
I guess it's yet another incidentaloma.
Incidental finding, yeah. Yeah, it's interesting. Yeah, I would be perplexed just like you because I have really no idea why. And but I'm glad you ever got the follow through to make sure there was nothing else that we missed. So.
Yeah. All right. Well, I'm glad it's not.
Well, thanks, Eric, again.
Well, thank you all.
Yeah.
We are several minutes from 9, so I wish you all a good night, and thank you for your attention and participation, and we'll see you next week.
All right. Thanks, Eric. See ya.
All right. Be well. Bye-bye.